Dr. Griffin is a clinical and forensic psychologist with a specialty in forensic assessment of children and families, particularly with regard to childhood trauma. She has expertise in childhood maltreatment and trauma, psychological assessment, and high conflict relationships and divorce matters. Dr. Griffin is a nationally recognized expert in trauma-focused cognitive behavioral therapy, or TF-CBT, and is the only nationally approved TF-CBT trainer in Massachusetts. In 2012, Dr. Griffin was awarded a 4-year, $1.6 million National Child Traumatic Stress Network grant by the Substance Abuse and Mental Health Services Administration to develop the UMass Medical School Child Trauma Training Center, which is focused on training, treatment, and resolving access issues for court-involved youth who have experienced trauma. With that, I will turn it over now to Dr. Griffin.
Great, thank you everyone. Good afternoon everyone. It's wonderful to be here today, and I have a lot of material I'm going to cover over the next 45 minutes, 50 minutes or so, and then open it up for questions at the end. I will be talking about some of the trauma initiatives here in Massachusetts, and then trying to move quickly over into an overview of trauma-focused cognitive behavioral therapy. So here we go. These are my commercial disclosures. I receive funding from the Substance Abuse Mental Health Services Administration and the Administration of Children and Families, as well as some local foundations and a television network. Okay. Evidence-based treatments. So very briefly, what are evidence-based treatments and why do we care about them? Evidence-based treatments are treatments that we know have research to support that they actually work. So treatments that work, that have been tested the same way that we might test a medication, for example. So if I go to my doctor to get a prescription for an antibiotic, I want to know that that antibiotic has proven to be effective to treat my strep throat. And so these treatments go through the same kinds of rigorous scientific studies that we use to test medications. So treatments like trauma-focused CBT has gone through that same sort of rigorous research process. To learn the evidence-based treatments, it typically involves quite a bit of learning and consultation in that particular treatment model, which I'll talk about here momentarily. Where can you find out information about different evidence-based treatments for trauma? Two source would be the National Child Traumatic Stress Network site that's listed here. There are some other resources on here as well. And I believe that all of these will be available on the Spark website for everyone to review, in addition to my slides, which will have links to all of this information and the resources that I'll talk about today. Briefly, just to talk about the history of trauma work and treatments around evidence-based treatments in the Commonwealth. Starting back in 2006, actually in central Massachusetts, we had our first learning collaborative in TF-CBT through another SAMHSA system of care grant here in the Worcester area. And that sort of really kicked things off in the evidence-based treatment world when it comes to childhood trauma in our state. And in the last decade, we've had a tremendous number of initiatives and projects focused on trying to really spread the training in different evidence-based treatments for trauma. In 2009, we received a National Child Traumatic Stress Network grant with LOC up in Fitchburg to start the Central Massachusetts Child Trauma Center. And then in 2012, we were funded here at the university to establish the Child Trauma Training Center. I can now today state that as of last week, we were notified that we are refunded our center until 2021. And so we will be available here at UMass to offer the training and resources I will talk about today for the next 5 years, and we expanded our catchment area to include the entire state of Massachusetts. So that is our great news I get to share with this group, and I think that's the first time, other than sending out an email yesterday, that I've been able to state that publicly. Okay. Many of you may have heard of the Massachusetts Child Trauma Project. That's an initiative we've wrapped up with the Department of Children and Families, where we've trained providers across the state in a number of trauma treatments for children, which I'll list here in a moment. the Defending Childhood Initiative. It was a similar effort that we had focused in the Boston area. And then there have been a number of funded National Child Traumatic Stress Network centers across Massachusetts since the year 2000. And I will list a few others up here. I included in this set of slides, and I'll send these off to you, Dee, the brand new grantees for this latest grant cycle, which will also be resources to you all depending on where you live in the state. Okay, so I'd like to just play a brief video here, and this is about the National Child Traumatic Stress Network, which is a wonderful resource for consumers, for schools, for physicians, for anyone working with children who've experienced trauma. We have all sorts of fact sheets, tools, even webinars on the National Child Traumatic Stress Network website that are freely accessible at no cost to our community. But I wanted to just play this video just to let you know a little bit more about the resource for you.
Children don't remember. Children get over it. That's been the conventional wisdom for many generations. But for many children, that's more of a wish than a reality. Because for the victims of child trauma, recovery and resilience are anything but guaranteed. Although it's not always visible to the outside world, child trauma changes the course of a life. The scars can become a permanent part of who they are and how they see and react to the world. It affects their relationships, their families, their jobs, their sense of self-worth. Often, child trauma becomes lifelong trauma, and it's a tragedy that occurs each and every day in America. Each year, half of U.S. children aged 17 and under are victims of a physical assault. 1 in 4 witnesses violence. 1 in 10 suffers sexual assault. In one recent year, HHS reported that 772,000 children experienced abuse or neglect. Society also pays the price. Up to 93% of youth entering the criminal justice system have been exposed to child trauma. And of course, significant costs are incurred by families, school systems, law enforcement, social services, healthcare providers, and systems. How significant? One study estimated the annual cost of child abuse and neglect to be nearly $104 billion. Child trauma is a national tragedy. Fortunately, now there is help. Now there is hope.
SAMHSA's National Child Traumatic Stress Network and its partners are hard at work. They've become the expert source for information, resources, and treatment. They're fighting the consequences of child trauma every day, helping children and families, developing new therapies, moving best practices into real-world use, counseling more survivors, providing effective treatment, letting survivors know they're not alone, changing the course of children's lives by changing the course of their care. We can't always prevent the trauma itself, but together we can minimize its impact on all of us. Now with your help, even those with the darkest past can enjoy a brighter future.
Okay, so that was just a brief overview of the National Child Traumatic Stress Network, and the website to access the network is nctsn.org, which is also in these slides, and I'll pull up at the end here too. Okay, so our last cycle of grantees included folks across the state, Bay State Family Advocacy Center out in Springfield, Luck site I mentioned earlier, a Category 2 site at the Child Witness to Violence program in Boston. We have another center focusing on refugee children out of Children's Hospital, and Institute for Health and Recovery in Boston, the Trauma Center at JRI in Brookline, and us, which we were focused on central and western Massachusetts, but in this latest cycle we have expanded, as I said, statewide. So the goals of our center were to provide, and this is pretty consistent with what we're doing this next round, is providing trauma-informed training to all sorts of groups that interact with children. And if anyone's interested in training opportunities, please feel free to reach out to me after today's webinar. But we're providing trauma-informed training for all sorts of groups, courts, law enforcement, teachers, physicians, and others who are working with children who may have experienced trauma. And then what we're trying to do is help to get children into treatment as fast as possible. One of the things that we've been trying to combat through our effort is the amount of time that children and families are waiting for treatment. With in some agencies, they're waiting 6 to 12 months for that first therapy appointment, which is just not acceptable. And what we've tried to do through our centralized referral system, which is 1-855-LINK-KID, is to try to get children into treatment as fast as possible. So we will process all our referrals through our center. We track wait lists at different agencies and so on. I'll talk a little bit more about that later on. And the last thing we're doing is providing training to mental health professionals in trauma-focused cognitive behavioral therapy. Our target goals we exceeded in this last cycle. We said that we would train 1,800 professionals, and we trained over 13,000. We plan to impact 20,000 youth, and we've impacted so far over 160,000 youth. We have, as of our last quarterly report, had enrolled 822 youth into treatment of our goal of 900, and expect that we will meet that 900 by the end of the month. So not every area in our state has evidence-based treatments. We're trying to address that problem through ongoing training initiatives. There's a number of reasons for that. It's limited resources. It costs money to train providers in evidence-based treatments and to keep them sustained in agencies. Wait lists are high. Clinician turnover tends to be high in certain agencies in certain regions. On our statewide effort, we found that about a third of clinicians will turn over during the year of training in the evidence-based treatment, and that just the demand for trauma treatment outweighs our current capacity in the state right now. So if you cannot find an evidence-based treatment provider in your area, so someone who's trained to provide trauma-focused CBT, you want to make sure that they're able to at least provide some sort of trauma-informed treatment. So it doesn't have to be an evidence-based treatment. That's ideal, but if you're not able to find that, and we want to get children into treatment as fast as we can, you want them to include these sorts of components in the work that they're doing with children and families. So are they screening and using assessment tools? Do they know how to build a strong therapy relationship? Are they providing information about normal responses to trauma? Is there a caregiver element involved? It's so critical to be working closely with parents, caregivers, whoever's in a caregiving role for that child when you're doing some treatment that has a trauma component. Are they knowledgeable about child development? Do they know affective expression regulation skills or feelings? Are they able to talk about feelings, help children understand how to express their feelings more effectively? Are they working on stress management, how to reduce anxiety, how to help children improve their relaxation skills? Are they doing some sort of work around cognitive processing or reframing, helping to challenge children's thinking, such as, it's all my fault, I was sexually abused? Are they able to talk to kids about those kinds of thoughts? Is there some sort of trauma narration or organization? So giving kids an opportunity to talk about what happened, help them make that unspeakable more speakable for them. And lastly, are they promoting safety? And many times we want to make sure they're promoting safety in every session with the child and family. Right. Does every child who has experienced trauma need an evidence-based treatment? Absolutely not. Not every child who's been traumatized needs an evidence-based treatment or even treatment. In that children can be resilient. Trauma, unfortunately, is a very common occurrence, and there are a lot of factors that go into how resilient a child may be. So you want to look at, is there a traumatic event or series of events? And for many kids we work with, for example, in our project here at UMass, the average number of types of trauma that kids experience is almost 6 different types of trauma. So we need to have at least one type of trauma as well as some sort of trauma-related symptoms. It does not mean that they have to have post-traumatic stress disorder, but some symptoms so that we know that the trauma has impacted this child's functioning and that there's a change in their functioning and it's impacted them in multiple domains. That's why that assessment piece is so important. If you do not ask about trauma, most of the time kids are not going to just freely volunteer that information. So we're really working with whoever professionals we're training and talking with. Are you asking questions about trauma? What kinds of questions are you asking? It is okay to ask those questions because most of the time if you don't ask, and there are rare exceptions to this, but if you don't ask about it, you're not going to have that information. And that could be really important information depending on what your role is. You know, for example, we do a lot of training for attorneys and work with attorneys to understand, have you asked about this child you're representing's trauma history? That may help explain some of the behavior that they're seeing. That may explain what their behavior in the courtroom. So we're working with attorneys on how to ask those questions. Okay, symptoms very briefly here. So trauma can impact kids and adults in a variety of different ways, and it can look different from one person to another. As I said earlier, people can be incredibly resilient. We could all go through the same traumatic event, everyone on this call or webinar, and about a third of us won't be affected. And that's dependent on a number of different factors related to resiliency, which is a whole separate talk here. We are very acronym happy in the trauma world, so bear with me when I use acronyms, and I'll try to spell them out when I can, but one that we use to organize trauma symptoms is CRAFS. So the symptoms tend to fall into these different domains. So cognitive problems, so difficulty paying attention, difficulty concentrating, difficulty focusing. May see some academic decline, even some developmental disabilities for kids who've been exposed to trauma over a long period of time, or developmental delays for children who've been in chronically neglectful homes or multiple layers of trauma. Relationship problems, so this could be with their peers, with romantic relationships, but difficulties with attachment. So we may have children who are indiscriminately attaching to people. So this may be a child who comes into your waiting room or whatever setting you're seeing youth in, and who tells you the first day they meet you that they love you or want to sit on your lap, versus the flip side of that, where we have kids who keep you at way more than an arm's length. So trauma does impact the way we relate to other people. Affective problems, that just refers to feelings and mood. Do we see disturbance of mood, more depression symptoms, anxiety, and so on. Family problems, we know that trauma doesn't just impact that particular child, but it can devastate a family system or have significant impact on a family system. Traumatic behavior problems, this would be things like in young children reenacting in their play. So I worked with a little boy who was in a car accident with his mother, and his mom was killed, and he had some minor injuries, but he would continue to crash matchbox cars into each other over and over and over again in every session, and would reenact this in his play. In older youth, we might see other types of traumatic behavior, whether it's cutting, other self-destructive kinds of behavior, poor relationship choices, and so on. Somatic problems would be things like bodily complaints, headaches, tummy aches, frequent trips to the school nurse, and other bodily symptoms. Complex trauma, I'll just talk very briefly about complex trauma, but this refers to youth who don't go through one type of trauma on one day, but children who have had multiple layers of trauma, so multiple traumas over a period of time, usually starting in early childhood and usually involving a caregiver. Not always, but usually involving a caregiver. So they grow up learning that the people in my life who I'm supposed to trust, who are supposed to take care of me, hurt me or leave me or don't meet my needs. And that's an ongoing, long-standing theme in their lives. And so what we've found, and researchers have found, and clinicians over the years, is that youth with complex trauma treatment tends to look different. It may take a longer time even just to establish that trusting relationship. We need to focus more on attachment, and we may be addressing safety at every session. So there are ways in which that complex trauma, multiple traumas over a period of time, don't always result just in post-traumatic stress disorder, but you may have post-traumatic stress disorder, but it may also impact them in multiple domains of their functioning, from relationships to their own biology. Okay, so currently in Massachusetts, right now, the main evidence-based treatments that are being disseminated are trauma-focused CBT, which I will be talking about here in a minute, child-parent psychotherapy, which is for young children ages 0 to 6, attachment, self-regulation, and competency is an evidence-informed practice. They don't have a randomized controlled trial yet, but a terrific treatment focused on complex trauma. And parent-child interaction therapy is the newer one in our state, where folks out of Judge Baker Children's Center are providing training in PCIT. And as we have more initiatives in this latest round of funding and additional treatments come into the state, we will also include these treatments in our Link Kid referral system, and I'll talk more about that here. So those are the ones being widely disseminated. How do you know if a clinician's been trained in these? You want to ask. The training looks different across the treatments. We suggest that if clinicians are trained in one of these evidence-based treatments, they're trained through some sort of learning collaborative or learning community model where they're trained with a group of people over a period of time. That includes a basic training, supervisor training, and consultation while they're working with children and families. It really have found that that helps to deepen the level of learning and improve the practice in that model, and we can ensure fidelity to those particular treatments. Some of the treatments have national certification programs or rostering systems that they're just starting to roll out over the last couple of years. This is an example of what a learning community or collaborative would look like. So you have your basic training in that treatment, and then there may be a supervisor training, an advanced training that's 4 to 6 months after that first basic training. But there's monthly consultation as well as team meetings within agencies or amongst clinicians. We also have evaluation data that we collect during the course of that training year. Okay, trauma-focused CBT. So that is a picture of the TF-CBT original manual, which was released in 2006, and there are a couple of new materials I'll highlight at the end that are also available. So TF-CBT was developed by Judy Cohen, Tony Manarino, and Esther Deblinger. Judy and Tony are at the Allegheny General Hospital out in Pittsburgh, Pennsylvania, and Esther Deblinger is now she's with Rutgers. And the TF-CBT is an evidence-based practice, as we talked about before, for traumatized children, adolescents, and their caregivers. Although children are the identified client in this particular treatment, we're focusing on children. There's a very heavy caregiver role in TF-CBT, but we do think about caregiver relatively broadly because not every family that we work with has biological parents that we're working with in treatment. We may be working with foster parents. We may be working with someone else who's in a caregiver role, whether it's an auntie or a baseball coach, whoever's in a caregiver role for that child. We may want to bring them into treatment to help to support the work that we're doing. So it's a hybrid model. So even though it's trauma-focused cognitive behavioral therapy, the CBT at the end, it really is much more of a hybrid treatment approach. There are some CBT practices and principles that we see in some of the treatment components, but it really is more than just a CBT model. There's a very heavy emphasis on family systems work and attachment, and as well as those cognitive behavioral principles. So the age range right now, our youth ages 3 to 18 years, although we will be piloting TF-CBT with an older age group here for transition age youth, hopefully with this new round of SAMHSA funding. Any type of trauma could be addressed in the TF-CBT model, so it could be a single type of trauma, such as a house fire, to children who've had multiple traumas over a period of time, and complex trauma. Need to have some sort of trauma symptoms. It could be PTSD, but does not have to be PTSD. It could be depression, anxiety, or other trauma-related symptoms. Although that caregiver involvement, as we talked about earlier, is ideal and optimal, it is not required. So you can do TF-CBT without that caregiver component, although we'll work closely with clinicians to identify who could potentially serve in that caregiver role. Done in a number of settings, so from based outpatient settings to schools, inpatient. We're doing a tremendous amount of this within the in-home therapy setting, as well as other settings. We have a very large body of evidence that TF-CBT works. There are over 19 randomized controlled clinical trials that have been conducted, and that makes TF-CBT the most rigorously tested treatment for childhood trauma to date. There are no other trauma treatments that have the evidence base that TF-CBT does. It's also been around the longest, so we've had more time to conduct those trials, and some of the other treatments that are available are also really terrific treatments for kids. What we've found, and I'll just give my very brief summary of the research, when you compare TF-CBT to a treatment as usual, so client-centered therapy or child-centered therapy, to some sort of control group, the good news is that kids in both treatment groups, TF-CBT and treatment as usual, do better. So that's great. So even if you're not doing TF-CBT, children are doing better in the client-centered or child-centered treatments versus the control group. However, children in the TF-CBT groups do better faster over many more symptom domains, and their caregivers also improve, and those gains are sustained over time. So caregivers who are participating in the model also have decreased depression, improved confidence and competence in their parenting abilities, decreased parenting stress, and we see significant improvements in trauma-related symptoms in children, anxiety symptoms, behavioral problems, compared to both groups. Right? And we have done studies in a number of different places. The original study started in the United States, but several of the more recent research studies have included youth who are in the Democratic Republic of Congo, in Zambia, in the Netherlands. We've had TF-CBT research trials looking at war-exposed children who were child soldiers, youth rescued from brothels in other countries, and sex trafficked victims. So when we think about can you use TF-CBT for complex trauma, the answer there is absolutely yes. Here's just a list of some of the newer research studies that have come out. Most of these are outside of our country. Illinois foster care study it was a very large study looking at comparing kids in TF-CBT with a typical system of care in Illinois who are also in foster care. Very briefly, our data here, we just did another download in the last couple weeks here. We have almost 300 youth in our project, almost anywhere between 5.5 to 6 types of trauma. So that's different types of trauma. So domestic violence, sexual abuse, community violence, physical abuse, and so on. So that's very high, as you can see. 40% of kids in our study have identified as Hispanic, which we're really proud of because we've done so much outreach to try to better improve access for Latino and Hispanic families. And we have not yet written this up yet because we just found out in the last few weeks, but our data, when we look at all of the different measured domains, children before and after TF-CBT have showed clinically significant improvements in all but one area of 20-something different areas that we measured. So it's really terrific news for kids who have received treatment here locally. TF-CBT is both a components-based treatment and a phase-based treatment. And we are providing gradual exposure across all TF-CBT components. So we're helping children be able to talk about trauma in a gradual way over time throughout the course of treatment. Just a few, if you look at this slide, it lists the treatment components there on the left, starting at the top with psychoeducation all the way to the bottom, which is enhancing safety. Those are the components of TF-CBT, but you'll see that it's broken into 3 phases. So first is the stabilization phase. That's where we're really teaching coping skills. The second phase is the trauma narrative phase, where we're helping children tell their story about their trauma experiences. And the last phase is really an integration consolidation phase, where we're trying to bring it all together in treatment, help children make meaning out of what's happened to them, focus on safety, and then what do they want their future to look like? What do they want their future relationships to look like? And those types of themes we'll address in that last phase of treatment. Here's another slide. I have a couple here that just show you what treatment might look like over time. So here, this would be an 8 to 16 session model. So this is not for complex trauma. So this is 8 to 16 sessions. You can do TF-CBT from 8 to 16 sessions from start to finish. The whole time we're working on parenting skills and gradual exposure to trauma. But here are those phases again. So your coping skills are in that stabilization phase. The middle phase is your trauma narrative phase, where they're telling their story about their trauma. And the last third is the integration phase. When we're working with complex trauma, however, it looks different. So you may need to double the number of sessions from 16 to 25 sessions. No more than 30 sessions, though, from start to finish in TF-CBT. When we see that happen, we become concerned that there may be other issues that are contributing to treatment taking that long. It should not go more than 30 sessions, which, if you think about it, is less than a year of treatment if they're being seen weekly. Parenting skills, again, and gradual exposure happen throughout, but you'll see that we start with safety rather than psychoeducation. We're starting with safety, and the first half of treatment is focused just on that stabilization phase, safety and coping skills, with the second half focused on trauma narration and that integration phase. All right, so 16 to 25 sessions should be no more than 30. I always get concerns about when clinicians are learning about evidence-based treatments. It's going to be like a cookie-cutter approach or feel like a cookbook, and I'm here to say, as a clinician and someone who supervised folks for the last 15, 16 years in TF-CBT, that it does not feel like that when you're actually practicing the model. You're very much able to use your clinical judgment, and ultimately, when we're on calls, I'm on calls with clinicians and doing some case consultation, and they'll ask a question. A lot of times I'll say, what would you do if you weren't doing TF-CBT? And 90% of the time, that's going to be the answer. So it's not going to make you a good clinician. That comes first. There's a lot of flexibility in the model, and sure, there are components that we do need to watch, and part of my role with clinicians is to make sure that they're following the model with fidelity, going through each treatment component in the order that they are expected to be administered. But there are a number of ways in which we can be creative with implementing the components, from using music to different YouTube videos to help illustrate a point. If we want to use play therapy techniques in there, we're able to do that as long as you're maintaining fidelity to the model. There are some myths out there about TF-CBT. I'll just hit a few of these. I think I've talked about some. Yes, you can use TF-CBT if there's no parent or caregiver available. Yes, you can use TF-CBT with kids in foster care with complex trauma. The age range, again, is 3 to 18, although we are going to be expanding that here for transition age youth. For youth with developmental delays or disabilities, you can absolutely use the TF-CBT model. We do additional training in what that treatment looks like with youth with developmental delays and disabilities. And TF-CBT has been implemented and studied with kids from a variety of different cultural backgrounds, settings, geographic regions, and so on. So here are your treatment components: psychoeducation and parenting skills, relaxation and stress management, affective expression and regulation, that's just our fancy phrase for feelings, cognitive coping, the trauma narrative, in vivo exposure, joint parent-child sessions, and that safety component and future development. So I'll talk about each of these very briefly. So the psychoeducation component, this is where we're providing information about trauma. This helps children understand that their past has actually affected their present. The behavior that we're seeing, Johnny is not this bad kid who does bad things, but that bad things have happened to Johnny, and Johnny's body and his brain are responding exactly as we would expect them to based on what he's gone through. Unfortunately, it's getting in the way of his functioning now. Kids who've been through traumatic experiences sometimes feel like they're going crazy, and so part of what we're trying to do is normalize their responses and also normalize the responses of caregivers after having a child who's been traumatized. And helping caregivers see that those behaviors that are driving them nuts may in fact be related to the trauma that the child has experienced. Okay, parenting skills. The next component is we're working very closely with caregivers across treatment components and trying to improve positive parenting practices in that parent-child relationship. We use a number of techniques to do so, but we do that from the very beginning because that typically children's behavioral issues are what's bringing them into treatment in the first place. And so we're trying to address those right away, and we do that within the parent component here as well, but also providing parent support and throughout the process. Even if you have a caregiver who comes in and doesn't believe that their child has been abused, you can still work with them in this model. We may not bring them together with their child until we've had some time with that, but helping to support the parent in wherever they are in their own understanding of the child's trauma experience. Relaxation, stress management, this is where we're trying to reduce that hyperarousal that many children have who've experienced trauma. So when their brains and bodies are working on overdrive and their physiology is used to having heightened levels of cortisol, norepinephrine, adrenaline being released through their bodies frequently, that's going to result in things like irritability, restlessness, difficulty sitting still. So what we're trying to do is reduce that hyperarousal so they're able to attend better in treatment, but also that can improve a lot of the symptoms that we may be seeing outside of the therapy session. So we're trying to reduce that physical signs of stress. And we do that in a number of different ways and techniques, from deep breathing to other techniques that may be considered more out of the box, but they work for that particular child. So when we're working with an adolescent, we'll talk about what makes you chill. It may be that shooting hoops helps them to relax, and so we may include that into a relaxation menu that we work from with that family. But we're approach the relaxation component very creatively, but also provide training in more traditional relaxation techniques. Affective expression and modulation, we're helping kids be able to better identify their feelings, increase their feelings vocabulary, and then express them more effectively. And the idea is that if children are able to name the feelings and express those feelings more effectively, they're less likely to use more maladaptive strategies or symptoms that are getting in the way of their functioning and or impacting their relationships. Cognitive coping and processing, this is where we're helping children and adults address their thoughts that may not be accurate or may not be helpful, such as it's all my fault, I was sexually abused, or you never know when someone could come in your school and start shooting. So we're working very closely with kids to identify how to change those thoughts, how our thoughts are related to our feelings and related to our behavior, and that if we impact or change the way we think about a situation, we can have a really big impact on how we feel and what we do with that, and then how other people behave toward us. The trauma narrative, this is what I think sets TF-CBT apart from some of the other treatments in that we do emphasize the development of a trauma narrative in treatment, so where children tell their story about what happened to them, about their traumatic experiences. And we do this in a variety of different ways, but this is done so that we can help to desensitize children to any trauma reminders they may have, decrease the physiological response they have to trauma, help them to make meaning out of their experiences, and also be able to communicate this with caregivers so that ultimately when treatment is done and we're no longer working with youth, they're able to go to their caregiver should they have a memory again that, or be re-triggered by something on a particularly bad day. So they're able to talk with their caregiver more comfortably about it. And we do this over a period of time. It's done gradually. We don't jump all in at once, but we do this over a gradual period of time, and they're able to tell their story. So they could do it in the form of a chapter book or a 3-act play. If they like theater or if they like music, they can write a song about it. So we work with kids to identify how they might want to tell their story about what happened. The in vivo component is one of the components we don't always do. This is where we work with children to develop a plan regarding a feared situation. So it may be that they're afraid of going to the bathroom in a public restroom, or fear of sleeping in their own bed, or a fear of going to school. So we work on an in vivo desensitization plan, also known as baby steps, to help them be able to conquer that feared situation. Joint parent-child sessions. So this is where we bring children and their caregivers together for children to share their trauma narratives with their parents. But there also may be other points in treatment where children and caregivers can come together around neutral topics. Let's say we want to have a session about psychoeducation and about safety. We bring everyone together to do a joint session around that. So if the clinician determines that it's appropriate to do so, you may have joint sessions earlier in treatment. But toward the end of treatment, most of our sessions are done in parent-child group family sessions, so that we're trying to promote that communication, encourage healing from the trauma. And the last component is focused on safety, so both bodily safety but also psychological safety. We'll talk about what trauma triggers are, trauma reminders, how to plan for those. We'll also talk about future development, making meaning about what's happened to them. So for example, what would you tell other kids who were sexually abused? Or what would you want people to know if they lost someone close to them in a house fire? Okay, and so exclusionary criteria. TF-CBT is not appropriate for kids where we don't know what the trauma is. We suspect that there's something bad that's happened to this child, but we have no idea what it is. We would not do TF-CBT with that child. We need to have at least one identifiable trauma. Now, you can know at least one and suspect that something else has happened. So let's say you know there's been domestic violence, but you suspect that this child may have been sexually abused. That's okay. You can certainly refer that child to TF-CBT. If a child does not have any symptoms and they're doing just fine, they would not require a full course of TF-CBT. You might want to do something abbreviated, talk to them about how to keep themselves safe and things, warning signs to look out for, and some psychoeducation about trauma, but they would not require a full course of TF-CBT. Children younger than 3 would not be appropriate for the TF-CBT model, and there are some 3 or even 4-year-olds that may not be a good fit depending on where they are with their verbal skills and developmental functioning. They need to be able to talk about what happened and have a memory of their trauma experiences. If youth are actively suicidal, psychotic, or substance abusing, meaning that they're intoxicated in session, not that they're just reporting, well, I smoke weed with my friends. Those who are actively substance abusing, meaning that they cannot stay sober in session, or if they're actively suicidal or actively psychotic, we would not do TF-CBT with those youth until they're better stabilized. It's been adapted for a number of different settings and populations, from developmental disabilities and young children to juvenile justice settings, military families, and other groups. There are multiple resources available. There's a treatment manual, additional texts available. There's a web-based training that folks can do in TF-CBT and also childhood traumatic grief. And if you've done those, you have access to web-based TF-CBT consultation. By the way, those are all free, and I'll pull the websites up for those. The National Certification Program in TF-CBT is at tfcbt.org. This is the online training, so this is free. You can take online. They're actually updating it this fall. I don't know the release date yet, but I do want to let folks know in case you go to do it, and then next month the new one's up. They released this back in 2005, 2006. And there's the web address if you want to look at the online training. How to make a referral to EBTs. You could contact agencies who've been trained already ready, but what we're trying to do is utilize the LinkKid system that we have here. We are available statewide now and have a very large database of providers who've been trained in a variety of different evidence-based treatments, including TF-CBT and others. So anytime there's an initiative in the state that does trauma training for EBTs, we're trying to connect with those clinicians to enroll them in our database and try to make referrals to those agencies. We're tracking wait lists and so on. And again, this was developed out of a need to improve access. Children were waiting just way too long for treatment, for trauma treatment. Despite all of these different training initiatives that have been done, kids are still continuing to wait. Sometimes when we first were starting, 9 to 12 months for a first therapy appointment, and these were traumatized children, which is not okay. So because we know the sooner they receive treatment, the better. So we have 2 full-time clinical staff who've been trained in the different treatment models, so can work with families to help to make a referral. Anyone can call our line. We provide a trauma screening on that call and work with families to try to make the referral happen as quickly as possible for their children. And questions you can ask a provider to determine if they're trauma informed, and these will be in my slides, so I won't go through each of these, but you want to make sure that you're also asking questions of clinicians. If they're not trained in an evidence-based treatment, how do you know if they're trauma informed? Okay, are they able to talk about what their practice looks like? Do they have those components I talked about at the beginning of treatment that are components necessary to be a trauma-informed treatment? And these are from the National Child Traumatic Stress Network. And we are at our Q&A. So I will stop talking here.
Okay. Thank you, Dr. Griffin.
Thank you.
We do have a question that came in. Have you had the experience of working with families where the caregivers do not seem to be able to make use of what they're being taught through TF-CBT?
Yes. The answer to that is yes, and we will work very closely with clinicians to try to troubleshoot that, because you are able to go forward in TF-CBT and just do the child-focused components, but there may be other ways in which, let's say, a caregiver just is at a point in their life where they're not able to engage, or maybe they have their own trauma history and they're being triggered by the child's treatment or behaviors, and even talking about the trauma is just too much for them. So we'll work with them over time, and we may decide that, look, this particular parent, it seems that they would benefit from working with us around safety and psychoeducation, but as far as being someone who can sit and hear their child's trauma story or trauma narrative, it may not be the most appropriate decision. And so we may decide to work with additional caregivers who are other sources of support we could work with in treatment, but we really address that on a case-by-case basis.
Okay, great. Another question came in. Earlier in your presentation, you mentioned that in a study of TF-CBT that youth improved in 19 out of 20 areas. What is the one area where there was no improvement?
Great question. So this is actually my center's data here, and so it's 20-something symptoms. I don't know the exact number, but there's an area having to do with caregiver externalization, and so we're looking into what exactly we meant by that. But as far as the child's symptoms go, every single area that we measured for kids who are receiving TF-CBT through our project we had clinically significant findings from pre to post treatment, every single area, which we don't usually see. And so we're looking at the data again to make sure that that is in fact true. And we will be reporting out the results of that in a variety of different formats, from presentations to some research papers that will be coming out here shortly. But that's actually from our center.
Okay, great. Another question just came in. How does this approach work with kids with developmental disabilities?
Great. So there's a whole specialized training that I do with clinicians to focus on that issue, because it is more than just taking longer and repeating things. There are ways in which we modify treatment to really leverage a child's interests. So some youth with developmental disabilities have tremendous amount of strengths or interests in something, like let's say they have a fascination with math or Batman. How am I going to use Batman in every treatment component? But there may be other ways we want to change the structure of sessions. If I have a child I know I'm only going to get their attention for a total of 7 minutes, then I want to really think about those 7 minutes. And maybe I'm not going to see that child for an hour a week. Maybe it's 3 times a week for shorter sessions. And so it depends on the child. It depends on a number of different factors, but you can use the model. Yes, it does tend to take longer with youth with developmental disabilities. But there also are ways in which we make modifications. We do a lot more involving visuals, and for those who tend to think more in pictures, we try to involve more visuals in the work that we're doing. In addition to talking about things, we may involve more of the body, particularly if they tend to be more on the active side, and try to work with that particular child's individual strengths and how can we capitalize those on those in treatment to keep them more engaged. So if they're really interested in Teenage Mutant Ninja Turtles, I'm going to think about how I'm going to make Teenage Mutant Ninja Turtles into a cognitive triangle to teach them the difference between thoughts, feelings, and behaviors. So there are ways in which we will make a number of adjustments to treatment. But that's a whole separate training that we do with clinicians.
Okay. Another question came in. Are most of your TF-CBT therapists providers for Mass Health?
I would say, I don't know the exact answer to that. I would say most of them are providers of Mass Health, but also different types of insurances. We have in our efforts here done a lot of outreach to private practitioners as well, in addition to our larger mental health agencies. But I would say the vast majority of our clinicians do take Mass Health.
Okay. And another question has to do with how can independent clinicians get training in TF-CBT?
I'm so glad somebody asked that. So because this new grant just got funded, we are going to have a private practitioner's track in addition to training. So we're going to have a lot of training opportunities between our center as well as our partner site, Bay State Medical Center, was also funded, and they're doing TF-CBT training statewide focused on clinicians doing in-home therapy. So between the two programs, we'll have a lot of training opportunities for clinicians in TF-CBT. I'm going to pull up, let me just ignore the Q&A on my screen, and I'm going to go down to, this is Genevieve Kane House is our project director. You can email Genevieve or myself if you're interested in TF-CBT training, and we can let you know more details. Our first training for our project will be, I think, this spring, although we have some other initiatives that may be happening late this fall, but no one's decided on the dates or times. But yes, private practitioners will be able to be trained through our effort.
Okay. Another question that came in, how do you handle working with caregivers that do not speak English, but the youth do? And do you have trained bilingual clinicians, and do you provide the training for bilingual clinicians?
Yes, so we do have trained bilingual clinicians, and a large number of clinicians in our database are multicultural bilingual clinicians, and depends what area they live in as to what the wait times look like. But we do provide training to multicultural bilingual clinicians. In fact, our last training cohort, we did outreach and prioritized those clinicians in that training cohort, and I think that's why we see our numbers really reflecting that 40% Hispanic rate. We see as a big success of our project in engaging those youth, because we have providers, culturally competent providers, who are able to provide the treatment in English and Spanish.
Okay, we have a few minutes for a couple more questions. Actually, someone made more of a comment. As a family law attorney, it seems courts and attorneys are increasingly trying to discount childhood trauma by labeling it as parental alienation and using it to try to get custody away from the custodial parent. I'm not sure if that's something you want to comment on, Dr. Griffin.
Well, I think that's a really hot topic and a controversial one. You know, looking at parental alienation versus true childhood trauma is something that requires a lot of work in the form typically of an evaluator or somebody who's appointed by the court to look more closely at that, because there are instances in which children are led to believe that they have been traumatized by one parent when in fact they have not, or been abused by one parent when in fact they have not, and it does look more like parental alienation. But it gets really complicated. I think that we're doing a good job trying to work with the legal system in Massachusetts, and I'm hopeful over the next 5 years we'll do an even better job regarding training judges, probation, etc., and the impact of what in family courts.
Okay, we have time for just one more question. It's a long one. I'm just going to read it. As a parent of 2 children currently being treated for trauma, what should I expect about my involvement in the last part of the process following the narrative? My daughter, now 11, was emotionally, physically, and sexually abused by her brother, now 14, and the 2 children will be involved together in the final part of the treatment.
Okay, so I'm not sure about bringing the children together piece. I'd need to know more from that particular clinician around the thinking there, but a caregiver can expect in the last phase of treatment to be more actively involved in family sessions. So there should be more family sessions as you progress toward the end of treatment. It really is like you're passing off the baton from the clinician back to the caregiver to be the person that child can turn to for a source of support. So although they've been able to talk about their trauma with their clinician, there's no treatment that's going to erase the bad things that have happened to kids. What we're trying to do is help them be able to handle that more effectively so that it doesn't undo them, so that trauma doesn't define who they are, and that they're able to have mastery over what's happened to them. Part of doing that is allowing them to have someone to turn to when they're having a tough day, or maybe there's a certain time of year that reminds them of what happened and they need to lean on someone. We hope that it's whoever's in that role. So I would expect a lot more involvement in that last phase.
Okay. And with that, I want to thank Dr. Griffin for taking the time to present her important work during this webinar. We will be posting the webinar and slides to our Spark website. If you still have questions that you would like us to answer, you can email those to our webinar organizer it's deidre.logan@umassmed.edu. It will be in the same email that when you registered that you received. And lastly, be on the lookout for email announcements for future Spark webinars. Don't forget to visit our Spark website and to join our mailing list so you'll get announcements of those webinars when they're coming up. And always, you can find us on Facebook, Twitter, and YouTube.